Welcome to Neuro Navigators, a MedBridge podcast where we conquer challenging topics in neurologic and geriatric rehabilitation. Our aim is to deliver actionable takeaways for physical and occupational therapy providers like you through captivating discussions with influential practitioners in our field. To receive continuing education credit for this episode and access bonus resources, make sure to check out medbridge.com. Hello, I'm your host, JJ Mowder-Tinney, a physical therapist with over 30 years of experience working with people with neurologic deficits, as well as the aging adult population. I have multiple certifications, including being a board-certified clinical specialist in neurologic physical therapy and a certified exercise expert for aging adults. Today, I'm excited to be joined by Dr. Angela Reimer, a doctor of occupational therapy who is an expert in the area of stroke. Today, we will be talking about a critically important topic involving how we continue to support our patients who have had a stroke and their families after discharge. As always, you'll leave with recent research and actionable takeaways that you can incorporate into your care to sustain support for stroke survivors and their caregivers. Welcome, Angie.
Hey.
I'm so excited to have you on the podcast. I know your deep love for this patient population and really can't wait to dive deeper into this aspect. It's good for us to get started. Can we get started with you telling a little bit more about yourself?
Sure. I am an OT. I've been an OT close to 24 years. I started out my career in geriatrics and long-term care. Did that for a long time and kind of fell in love with the neurologic aspect of things and transitioned into more specialized neuro care over the years. So in the past several years, I've worked at the VA. I've worked in acute rehab, as far as from an inpatient and an ICU standpoint. And I've also spent a lot of time in outpatient neuro, which is where I currently work.
Nice. Can you tell us a little more about what attracted you to working with people specifically following a stroke? And then how this passion has kind of continued to focus on the need for support for them.
Yeah. So initially, I just fell in love with the challenge of neurologically impaired patients. I fell in love with patients post-stroke and just the everyday, it made my brain work a little bit differently and it fed my need to be creative. And I just really loved that part of treatment when it came to patients post-stroke. And then the more I started seeing these patients and their caregivers, then I really started to notice trends in their experiences and the trouble they have kind of navigating post-acute care and getting back to real life and trying to figure out kind of what that new normal looks like with them. So through that, I've started to help our local hospital that I work for build support systems and build programs to support these patients kind of longer term. And that's one thing that I do a lot now in the clinic.
So, and I know how much you love that. You're always telling me stories of how you're going above and beyond. So why do you think it's important to discuss how to support stroke survivors and their caregivers?
So I don't think we talk about it enough. So statistically, about 40% of patients feel completely abandoned by the healthcare system once they leave the hospital. So in the hospital, there's 24-hour care. We're providing all these resources. We're doing all of these things. And then it's like taking a newborn home. We're like, okay, here you go. See you later. Have fun with that. And we don't do a great job as a healthcare system with these transitions. So the transitions seem to be disjointed a lot of times. Patients and caregivers don't always have great education when they're leaving facilities and going to the next level of care, or really don't know what that next step looks like. So we really do need to be talking about this more. Also, when we look at this from a statistic standpoint, 25% of all stroke survivors are readmitted within 90 days. They have trouble with their medication management. They can't get their meds. They don't realize they have follow-up appointments, all of those good things. And 73% of these patients fall within 6 months of return to home. So I did a presentation several years ago for AOTA on this. And what I learned from that is caregivers and patients, they just don't feel like we're hearing them as a healthcare system in whole. I had a therapist come to me after the course we did And she said to me, my dad had a stroke several years ago, and this is the first time I feel heard, which made me want to cry. So I feel like there are just so many needs out there from the support standpoint. And we're not great as a healthcare system in the United States as a whole in meeting these needs and kind of digging through and seeing what can we do to help these patients post-acutely.
Oh my gosh. Those numbers, holy crow. Like, I didn't realize that those numbers were so big. I mean, I always had a guess about the falls and the readmission, but just that 40% of feeling abandoned by the healthcare system, I'm not surprised. I guess I'm just sad. Like you said, it's
Exactly.
sad. So from a clinician's standpoint, what questions do you think we could ask so that our patients are feeling heard, so that the therapist who came up to you after that talk, so they would feel heard?
So I think one of the biggest things that we forget about is mental health. We spend more time with these patients than anybody else in the healthcare system. So really asking our patients, on a regular basis, what's your mood been like? How are things going at home? Because we don't ask about that enough. And these patients are trying to figure out kind of, what does life look like now? What's this new normal look like? And it's a grieving process, right? So they're looking at what their life looked like before this, or what they thought their life or retirement was going to look like. And now they're like, holy smokes, what does the rest of my life have in store for me? So they're definitely go through those same levels of grieving as somebody who's had any other type of a loss. And I don't think we do a great job of explaining that to people and really digging in to that mood aspect and advocating for patients from a mood standpoint. So, if we're asking patients, how is your mood? And they're saying, oh my gosh, I'm so down, I can barely get out of the chair, then taking that to the next step of, talking to them a little bit and giving them resources, but maybe also going to their physician and saying, hey, have we thought about some kind of a med for this patient? Those types of things as far as advocating. I also think we need to ask, what's important to you as a patient? This is not my rehab. This is my patient's rehab. So no matter what I think is important, I've worked with patients where I'm like, have this whole laundry list in my brain. And then when I ask them what's important, it's like one specific thing that would have never, ever been on my radar had I not asked, So I always go back to a specific gentleman who had a caregiver that was he paid caregiver 24/7, and he could not do any of his ADLs. And in my brain, I'm having this guy needing to get dressed, bathe himself, and do all of these things. And he looked at me like I was crazy. He's like, I don't need to do any of those. I got Bernard. Bernard does those for me. I was like, okay, well, what do you need to do? He's like, I want to be able to hold my prayer book open at temple. That's what I want to be able to do. And had I not asked him, like, that wouldn't have been on my radar. So really knowing what's important to the patient is huge. And also what's important to you as a support partner or a caregiver. So what are the one or two things that we could work on in therapy to make a huge difference in your life? Because those are the things we need to focus our time and our efforts on. So I think those are questions we should be asking on evaluation. But I think they're also questions we should be asking kind of intermittently, as well as, what's driving you crazy? What's frustrating you? What's making you want to cuss? I ask that a lot. I'm like, today, what's making you want to cuss? What's frustrating you? Because that's where we need to start our treatment. And whatever's driving you nuts, that one little thing, right? So we really need to be thinking about our rehab and our goals and our interventions from a really client-centered and caregiver-centered perspective versus thinking about it from, okay, I learned in school that people should be able to do X, Y, and Z, and those are what I need my patient to be able to do, because not everybody's the same and not everybody wants to do the same things, We also, I think we need to be asking a lot more where they're getting their information from and what resources they've been given. So one thing I find, especially now, is the internet's a double-edged sword. So I have patients that are getting great information on the internet from really good sources. I also have patients that are taking information from their Facebook support group from another stroke survivor with maybe a cognitive deficit or not the same situation at all, who lives somewhere else in the country. So there's great information online and there's not great information online. So we want to make sure we're asking where they're getting that information and what information they need so that we can provide that information for them so they have good quality information.
I just want to, you just said so many things, so I want to unpack a couple of those. I just want to emphasize, I just wholeheartedly think like emphasizing the narrowing things down. What are the two most important things for you? What are the two most important things that could make your life easier to the support partner? I think, sometimes we get overwhelmed by thinking as therapists that we have to solve all of these problems. And then it doesn't allow us to really get enough repetition with the amount of time we can see people to really make the change that is the priority. So I love how you're prioritizing the patient's goals. And it's not that we don't. I mean, we all know that, but I just think we get overwhelmed with thinking we have to do everything. Letting the patient kind of lead us, and or the caregiver, depending on your situation and what setting you're in, I think are just so important. And from an OT perspective, like all of the different things that you all do and the overlap between PT and OT, that seems really hard in regards to you prioritizing all that. So I thought that was really great. But the other thing I just wanted to emphasize, because I mean, it's not like I haven't recognized that people get their information. I mean, you do get your information from everywhere, right? But for us to know where they're getting their information. So when they say, oh, but I saw this, and we're like, oh yeah, kind of, okay, you kind of swallow that, but instead diving deeper, is that kind of what you're saying? Like follow up when someone says that and try to understand a little bit more from where they're coming from.
Yeah, and if they're getting their information from a not great place, okay, what were you trying to look up? Can I give you a good resource for that? So, hey, I've got this handout about spasticity. Let me give you that. Or let's talk about this in the clinic so that we're making sure that they're digging for information, not ending up in the right spot. We're kind of detouring them back to where we want them to be, or in that spot of good clinical content versus, an advertisement for something crazy that vibrates their body all over and tells them it's going to cure them.
Right. And there's, and so thinking of that, because I was going to say there's little bits and pieces that we don't know yet. So that could be good maybe in the future, or this piece that they're bringing up, but we just don't know yet. So from the aspect of recent research and what recent research says, can you give us any highlights in regards to what you feel are the most important takeaways from that?
Yeah. So there's a bunch of really great qualitative research out there, which I love, because when you're reading this qualitative research, it really gives you kind of patient stories and perspectives. So kind of the most common themes in the research are, that mental health needs of not just the patient, but also the caregiver are often overlooked and not addressed. So that's one of the big things that's over and over and over in the research, is that mental health aspect of not just, again, the patient, but also the care partners, the families, because they're all going through the same lived experience of, oh my gosh, I've had a stroke, now what, right? The other thing, I talk to families about a lot is, this is a lot of togetherness. So even if you've been married, 50 years, 40 years, you're not used to being together 24/7. You were able to go do your own things, and now all of a sudden you're together 24/7, and that's a lot of togetherness really quick. So that really affects people too. The second theme that's really big in the research really looks at that therapeutic relationship between the patient and the care team. So the patients want hope. They want us to provide them with hope, but they also don't want to be felt like they were lied to or given false hope, right? That's that really fine line. but they want to have that great relationship with their therapist. They want us to be their cheerleaders. And the same thing with those caregivers. They want to be able to come to us as therapists and say, hey, this is going on at home and I'm not sure, is this normal or not? Or what should I be doing in this situation? So they want us to be that resource. So that's one of the other things that have come through. Another theme is just that idea of disjointed care. So post-acute care is just disjointed at times. These patients are already under emotional distress, and now they're trying to figure out the healthcare system, which is difficult, with maybe cognitive deficits, vision deficits. They have trouble with transportation. So those transitions are really hard. And I just saw this today in my clinic. I did an evaluation for a woman, and she had no idea leaving acute rehab when her follow-up appointments were for cardiology, for neurology, and these were really, really important follow-ups because she was like an open heart surgery that had a stroke during surgery. So just knowing kind of what those appointments were, how do I get my medications from point A to point B as I'm leaving, acute care or inpatient rehab and going home for that first time? What do these, how do we make this a smoother process for our patients? Because it's become kind of the standard of care in like cancer that we have these navigators, but we haven't gotten to that point in neuro yet. So patients are really trying to figure out what resources are there for them and how do they make this work long term. And then the other theme was really that need for education. Patients and caregivers both felt like they needed more information or more education, but not just more education, but providing education, the right things at the right time. So one of the things, we're a comprehensive stroke center where I work. And, the first thing we do when somebody has a stroke is we throw them a binder of material on day one because JCO says we have to, right? And we throw them a binder of material and either A, they don't even look at it because they're so completely freaked out they can't think, or B, they read it with a fine-tooth comb and now they're perseverating on the fact that they're 300% more likely to have another stroke and they're waiting for it to come any second. Mm-hmm. So really providing the right education at the right time in the right way is huge for these patients. And I think that's someplace that we really have a lot of work to do as a healthcare system as a whole.
Well, geez, can you imagine? I'm just listening to you go through all those different pieces that I don't always think about because I'm kind of focused. I was always focused on what I needed to accomplish, and that was hard enough. And so now you've listed all these things that I think are quite, I just can't imagine how overwhelmed people must be. And I'm thinking about your statistics telling them you're this much more likely to have another stroke. And then we're going in there saying, now you got to get up and you got to move and we got to raise your heart rate and we got to go hard. And, which is so critically important. But if we're not doing a good job with the education, just even within, and now this whole transition out, I'm surprised actually now, after hearing you say those things, I'm surprised that 40% isn't higher. Because, I know you, I know you, and I can see you go up and you say, hey, you can tell me, like you can talk to me. And I know that your patients love you for that because they know they can tell you things that they don't feel comfortable telling other people. And, and trying to build that relationship when you're also just trying to get all the things done as a therapist that you need to get done. Mm-hmm. And I don't think we do have the research, right? There's some, like you said, some qualitative studies, and I don't know this literature as well. Now I want to go dive into it. Thanks a lot, Ange. But there's that research, but like, how do you do that? How do you take that research and actually translate it, into clinic and how do you make that happen in a therapy session when you have such limited time? And you just listed a whole bunch of things that we should be considering.
So I think, an easy way to start is, mood is come up over and over in the research. It's not that hard to ask how's your mood been? You know what? This sucks. And It just does. And it's normal to feel like this sucks, and if it's normal to have bad days, but if you feel like you have more bad days than good days, we need to discuss this and I need you to come to me about it. That takes 2 seconds on eval to have that conversation and just to let people know, like, hey, I see you. I know this stinks. And that's completely normal. And if you were excited about this, like, I would be super worried about you, just so that they feel heard. And I think also just, that initial of really asking open-ended questions as you're walking somebody from the lobby into the clinic, or you're pushing them in the wheelchair down to the therapy room. Hey, how are things going at home? What's up? And asking those really open-ended questions, because I feel like we don't do a great job of communicating in that way sometimes. And I know for me, like, I'll find myself saying like, oh, the home exercise is going good, right? Like, and of course they're going to say at that point, oh yeah, it's going great. But like, I don't know if it's really going great or not. So I get a totally different answer if I'm like, hey, how's your home exercise program going? How often are you doing it? So by asking those open-ended questions, I just get more information, and then we start to develop some more dialogue versus kind of more closed questions. And also questions that don't require a yes or no answer. Are things going okay at home? Yep. And that's going to be, it's like having teenagers, right? That's the end of the conversation. So really being able to ask those questions in ways that foster better communication and foster more communication. And I think that's just something we have to get used to doing. And I still struggle with that, where I ask something and then I'm like, oh, well, I didn't get the answer I was looking for. So how else can I ask this, right? Also, just building that rapport, getting to know your patients. What do you like to do? What's going on at home? How did such and such go over the weekend? So really building rapport and building that trust, and also making them an active participant in their plan and all the interventions that you do. So what do you want to work on? What's frustrating you? Okay. We're going to pick 3 things to do in the clinic today. Here are your choices. Which 3 do you want to do? So really giving them control over what they're doing in the clinic and making them feel like an active participant rather than they're along for the ride. I think that's huge for so many reasons for our patients. So really thinking about that. And I also think just being their biggest cheerleader. We consistently can offer hope, but not false hope. And I will always tell patients, like, I will never blow smoke up your rear end. Like, I'm going to tell it to you exactly like it is, but I'm also going to be your biggest cheerleader. Like, I'm not going to lie to you, though. So I'm always going to say, nothing's impossible, right? So we want to provide that hope. They need that consistency. They need that from us. The research is also showing us, is providing that education and providing resources, not only on evaluation, but throughout everything we do. So if we are evaluating someone and we're noticing vision problems, can we provide them with resources on that specific vision problem we're seeing? Can we provide them resources on where to go to get an assessment? If they're aphasic, can we provide them with information on aphasia, or where to get an aphasia resource card for their wallet, so that if something happens, they have something to say, hey, guess what? I have aphasia, and show a card if they can't communicate, So how can we provide education at the right time for the right things? But I think also, how can we provide it in small enough chunks that it's digestible? So I think that's really big in developing some kind of library within our clinics, right? Of I can pull this and give it as needed. And then the other thing is, like, during these transitions, one of the complaints is disjointed care. Can we as therapists, especially OTs, somehow build this into our sessions? So as an OT, can I work with my patient on, okay, when are your follow-up appointments? Do we have those in a calendar? Do you know what your plan is to get your medication when you leave here? That's all home management stuff, right? So can we build that into one of our last sessions as far as making sure our patients understand, okay, here's what I need to do to follow up. Here are my appointments. This is when they are. This is where they're at. If I have questions, do I need to write a list of questions? But how can I help to facilitate those transitions so they're more smooth versus, somebody moves from inpatient rehab to outpatient and now they've missed their appointments because they didn't know they were scheduled. And, so how can we also maybe build some of that into our treatment plan as a whole?
Wow. Okay. So there was a lot of good points there. And a couple stood out at me just thinking about your resources comment, because you listed all these great things for resources. Angie, we need to make a list of those things so that then therapists who we talk to can take it and then give it to their student and have their students start working on finding those resources. Where would they find this resource? You were talking about, a vision resource, or I can't remember all the ones that you just listed. So we need to make a list of those, because I think therapists, you can get overwhelmed, but then utilize your students to start working on some of that so that they can help, give to the patient. And, you talked about autonomy, because that autonomy and motor control, giving the student, the student choices, but in this case, our patient and our caregiver's choices of, if you had to choose between these three things, what would you like me to focus on as we work together, in regards to that. So I think just re-emphasizing autonomy and giving patients control, thinking about your resources and start making a list of the things but have your students do the other. And then, that just going back to the beginning, I was thinking about, like, if you ask me, how's your mood? Like, that's a hard question to answer. Like, I have to think about, like, what is my mood right now? And I think, wow, that's just really comprehensive in regards to, like you said, open-ended and how things are going at home. But then I think as busy therapists, we need to listen and not feel like we have to solve that, but we're gathering information to take back to the team, because as a team, PT, OT, speech, nurses, doctor, all of us are a team, and we kind of all need to band together to try and remember that stat of them not feeling heard. Like, that is going to stick in my brain the most, because that gets right at our heart as therapists, that our patients don't feel heard. And I can just see the times that I did that, not on purpose, but just from speed and being busy. And then maybe I didn't want to hear the answer because I knew I didn't know what to do about it. Like, I think I know what they might say, so I'm just not going to ask because I don't know what to do about it. I'm exaggerating just a little, but I think if we recognize, just let them feel open and answer that, no matter, don't ask a question you don't want to hear the answer to, but that you are, and that you have a team to try and help you say, how could we problem solve through this for them? Because we're the key people to really support them through that. So, wow,
I think
that's a lot.
I think it's really important what you said, though, about team, because it's also important to know, like, who's on your team and what are their strengths. Because I know in my clinic, like, we have a coda on my clinic that's amazing with, like, biofeedback and guided relaxation and mindfulness. And if I know my patients is super anxious and they're going through this stuff, I'm like, let's schedule them a session with Ashley. So really knowing what that specialty is in your clinic and who's good with what, then using those resources within the clinic to meet the patient's needs. So I think that's amazing, just knowing what your team looks like even.
Yeah, because then it doesn't lay on me, because, like, that's not my thing. Like, I know a lot about very little, and anything outside that is just is overwhelming. So, and that's why I always call you. I call for help. I call my OT for help a lot. And so we have this here, and then, once they're discharged or after outpatient or home care, so it's just more resources, right? Is that kind of what I'm hearing you say?
Yeah. And I think especially if you're in, like, a skilled nursing or an outpatient rehab center or home health, where you're not discharging to another level of care, but you're discharging to, this is the discharge. I think this is where this is really, really important, because so many times I feel guilty discharging my patients because I know they need discharged, but I feel like, oh my gosh, when I discharge them, I know they're going to go home and sit on their couch and do nothing. And then I'm going to see them in Kroger 6 months from now, and their arm's going to look awful because they go home and then, I'm not there to be that little voice on their shoulder anymore, and they get depressed. And so really making sure as we're preparing people for discharge, especially from like that terminal end of therapy, right? We're not going to another level of care, that we're providing resources for ongoing care. So, are there, pro bono clinics from universities in the area that they can do a follow-up with, or they can go there during a neuro lecture and be, the person who they practice the Ashworth on, what kind of education can we give? Can we hook them up with like gyms in the area or exercise programs? And then I think the thing that we don't push enough or educate enough on the importance of are stroke support groups. So can we make sure that they have information or they're affiliated with some type of a support group or support system, not just the patient, but also the caregiver, before we're sending them home from that last level of care, or even from any of these levels of care? Because I think it's really important that we're providing that information.
Right? Because they could start it before they're...
Oh, yeah.
They could start being involved in that before they don't have any more therapy. But, sometimes I think because of the overwhelmment of going home and now just getting up and getting ready is exhausting and time consuming and hard. Are there any, how do you get people to buy in to help them carry over, or to be willing to go search for that? Because they have to make calls and they have to, search for those types of things you just discussed.
I just give them, we have a flyer for our stroke support group at the hospital, and on evaluation, I hand it to them. And I'm like, hey, guess what? We get together the first Thursday of every month. It's a really fun group. You should come hang with the cool people. And then when I see them the next time, if it's getting closer to the first Thursday of the month, I'm like, hey, you coming? Are you coming? We meet at noon. So do you want us to schedule your appointment right before or right after group, so you're already here from a transportation standpoint? And the speech therapists are big. We have lots of therapists that provide that kind of are part of our stroke support group. So then the more we're all talking, and then I'll also, if I see another patient across the gym, I'll be like, hey, you want to meet somebody? If it's somebody who I know is active in the support group and loves to meet other stroke survivors, as long as I know both patients and I know they're cool with it, I'll be like, hey, you want to meet somebody? And I'm like, hey, Joe, come on over here. You want to meet somebody? And introduce them and start to build those connections with, hey, Joe goes to stroke support group. Why don't you come hang out with us? So really trying to build those connections early on, but also, advocating for people to participate as they're in therapy.
Right. I mean, familiarity is always more calming to the soul. So the fact that you try to introduce people or try to get them so that they know somebody there, or they happen to be sitting next to someone, do you mind telling them about what we talked about in the last support group or whatever? I think that sounds extremely beneficial, because again, that just makes you feel, oh, I'll recognize someone. And it's because it's hard to go to places normally. I mean, it depends on your personality, but I think for a lot of people, it's like, it's hot out, or it's cold out, or it's windy out. I don't want to go.
Well, and not only that, even if they're not going to come to stroke support group, I find that they're curious about each other, right? So they're looking across the gym and they're like, ooh, what's wrong with that guy? I'm like, I can't tell you, but you're welcome to go talk to them, So they want to know, that guy kind of looks like me. What's his deal? How's he dealing with this? So I think they're naturally curious. So it's a good way to kind of introduce this in that way too.
Now, I know you talked about the importance of small, manageable chunks of information, because I just can see, do they really get a big, huge notebook?
Yeah, because JCO says they have to have all of this education stuff. So they'll get a big, huge notebook, or sometimes they put it on a TV channel in hospitals, and this TV channel plays But like if you have trouble with, you're aphasic, you're overwhelmed, you have vision problems, you're
That's not
having
going to work.
cognitive deficits, there's so much stuff that it's like, oh my goodness. And this is in the ICU. It's early on that we are required, quote, by law, to provide this to survivors.
Be interesting to kind of go through that and see how could you chunk that information. I mean, it's so hard because all the people that we work with who've had a stroke all present so differently, and they all have different strengths, and they have different family situations and discharges. And I think, it's so, that cookbook isn't going to work. And that's, we love to try and find what works for this person. Another reason we love this population so much, but that small manageable chunks, I think it is important as therapists for us to pay attention to how much patient education are we doing, and what is our top priority. We're the best people to disseminate or to like really figure out what is the most important thing right now that I could do for them.
Yeah.
Right. Because just saying this, and this to check it off my list is not going to be able to help them process.
Yeah, it's been on my bucket list for a long time, and I haven't had a chance to try it because, I got other things going on in my world. But I want to develop like an entire toolbox of like one pagers on, aphasia, spasticity, sensory loss, vision, whatever, and even on like frontal lobe. So when I ask patients, hey, do you know where your stroke was? They're always like, I don't know, over here on the left somewhere, So, your stroke was in your frontal lobe. Here's what might be affected. This is why you look like this. And George down the hall looks like this, So that's always been on my bucket list of things I want to do. So maybe someday I'll achieve it. I need a student or a personal assistant.
Well, I know you've done a lot. You've done a lot of those types of things for MedBridge. I mean, I know their library I know that you've done some really great stuff that's in their libraries. And so maybe put it out there in the universe. So many different ways to help you accomplish that.
Patient education materials on MedBridge. There are lots of great ones out there. If you have not dug into them, dig into them because I use them all the time.
Well, there's so many different things out there, but it's just knowing about them and being able to find them. So,
absolutely.
Okay, talking maximum impact here. If you were going to talk about your top 3 action, because we always like to, this podcast is about the top 3 actionable takeaways for clinicians so they can put it into practice. What do you got for us, Ange?
I think kind of top 3 things. Ask about their mood frequently. Consistently, often, frequently. Involve the patient and the caregiver in their plan of care and in their treatment, all of that kind of stuff. And then just, develop creative ways within your clinic to support these patients and their caregivers. So sit down as a clinic, sit down as a facility and decide, okay, what are we seeing? What trends are we seeing? What are patients telling us? And how do we fix that? So things like, resource libraries, education libraries, if you don't have a stroke support group, starting a stroke support group. And not just starting a stroke support group, but starting a stroke support group that meets the needs of your patients. Because those are 2 totally different things. I worked for a facility that we had a stroke support group, but my patients were young, 40, 50, 60-year-old patients. And they're like, we don't want to go to that. They're talking about like end of life and all of these, palliative care. And they're like, we're still living our lives. We want to know how to live our lives, not to end them. So we ended up building a secondary kind of on the down low stroke support group for our patients that were younger, which eventually just became our stroke support group. They shoved the 2 together, but really looking at what does our population need from a support group. I think that's huge. Introducing these patients to each other, coming up with ways to kind of build that community, because I think social support's huge, not only from that patient standpoint, but also from a caregiver standpoint. I cannot tell you the number of times I've had caregivers come to me and they're like, this has been so helpful to meet other caregivers because I don't know when to push and when to stop and when to help and when not to. So it's good to get input from other people, but also to know that like I'm not the only one that's struggling with this. So I think that's huge. Um, you know, a lot of what we do sounds like social work, right? So are there ways we can pull our social workers in our facilities and collaborate with our social workers and our discharge planners to kind of work as a team? And then I think also from a support standpoint to just celebrate accomplishments, big and small. Our patients don't make progress in leaps and bounds a lot of times. They're baby steps. And because they're baby steps, sometimes they miss that progress or they lose track of it. They feel like they're spinning their wheels. So, when they can do something little they couldn't do yesterday, I'm like, woohoo, you weren't able to do that yesterday and you're doing it today. And they're looking at me like, girl, you're crazy. But really reminding them. So even from like the standpoint of when I take range of motion measurements, I will literally hold the goniometer up and be like, okay, last week you were able to go this far. This week you're able to go this far. So they can actually visualize the movement, because 10 degrees is a random number, right? But when I can hold that goniometer up and show them progress, then it gives us something to cheer about. So I think that really celebrating those accomplishments of our patients, no matter how little they are, then that continues to keep them motivated to move forward.
Well, and you think about knowledge of results, right? And the research is very supportive of the knowledge of results. Like, get that little whiteboard. I'm obsessed about it, but I think everybody should have the whiteboard so that they're writing, gait speed before and gait speed at the end of the session. And this is where you were before. And just like you said, it's different when you just say it than if they can visually see it. Mm-hmm. And picking some of those top priorities. And then I think it also just reminds us as therapists that if we aren't seeing a change, we need to up our game. We need to increase intensity. We need to push them harder, further, because we can. I mean, there's just so much potential. And when we say, hope, that's what we give. And we know some of the biggest ways to provide hope is by pushing them harder but staying focused on their priorities. So I think that combination is what, requires us as therapists and our skilled therapy and interventions to really do. And so I think that ties in nice to what you're talking about in regards to just some of this. I mean, we do involve the patient, but I think it's just a subtle higher level of really thinking more specifically about how do you do that? How do you include them? What questions do you ask? Because it always reminds me of when people say, yeah, they have a fear of falling. And I'm like, so how did you assess fear of falling? We need to dive into that and be more specific if we really want to find how we can address that issue optimally. So I think that's really exciting. Now, I know you have started. I know you are a huge proponent and a cheerleader for stroke support groups. So, when you run into therapists who they're like, I would love to have a stroke support group at our facility, and they don't know where to start, what would you suggest?
A lot of times I'll say, just do it. Find those 2 or 3 patients. This is how we started, right? Mm-hmm. You find those 2 or 3 patients that are going to buy into this, and you get them together and you're like, let's have lunch. And, start really thinking about, okay, what do you guys need? So that's where we kind of started, was 3 patients were like, let's have lunch. This group wasn't meeting our needs, so let's have lunch over here. And then it's kind of grown, right? And it's morphed over time. But really, knowing there are some awesome resources out there. So stroke.org is awesome. It's the American Heart and Stroke Association's website. They have a stroke support group finder on there. So if you don't have a stroke support group at your facility, or let's say, I'm from Indiana, there's snowbirds. I can find a stroke support group in Fort Lauderdale, Florida for my patient to visit over the winter time if they need one. So there's a great searchable database, but you can also list your stroke support group on there for free so that people can find you. So that's a great resource as far as stroke support group finder. Also, if you go to that Strokes Association or Heart Association, stroke.org, and you go into the search box and you type like stroke support group or stroke support group resources, they have an entire webpage of how to start a stroke support group and resources for stroke support leaders, which is
nice.
all free. It's amazing. They also on their YouTube channel have a video called Stroke Support Group Strategies and Lessons. So they did like a webinar, and that's on their YouTube channel. You can again access that for free. And Jay, there's some familiar faces on it you would recognize from the Stroke Association. So that was kind of fun.
Oh, cool. I'm looking it out after this. I'm just saying.
Yeah. Rush Hospital has an awesome presentation online, and we can link these in the resources for you. But they have a great presentation or PowerPoint on how to sustain a stroke support group during and after the pandemic. And it talks about Zoom versus no Zoom. It has a lot of great information. And then there's also something called the Stroke Support Association that has a lot of great resources on their site as well. They're based out of California. They have a stroke support group that's been meeting since like 1980 or something like that. So just another good resource. But really, like for us, we sit down once a year, and we're like, okay, tell me what you want to learn about this year. And I take out a piece of paper, and whatever my patients tell me they want to go over, we write it down, and that's my starting point to find education and speakers for the year. And I think that it's important that we keep a balance of education and socialization to build family, because we want patients to get to know each other. We want caregivers to get to know each other. That way we build a community versus I'm going to come in and listen to a lecture and leave. So we do strikeout stroke baseball game every year at our local minor league park. So we go as a group and we do the whole, they say our stroke support group name over the big jumbotron, and we yell and wave our hands in the air, so thinking about what other things can we do, we do something at the holidays for the holidays. So really bringing in, what do our patients want and need, and how can we add value to what we're doing for our patients?
Those are great resources. We'll include them in the notes section for the podcast just so that they can access them.
Awesome.
All right. Love it. All right. To wrap things up, I'm going to count on you. Final words of wisdom would you like to leave the audience with?
I think the biggest thing we can do is not be afraid to ask the hard questions. So sometimes things are uncomfortable, or we're not comfortable with them at that time, but really asking those hard questions to our patients and figuring out from there, how can we support them best? If we don't ask them what they need, we're never going to be able to help them with what they need. So I think that's the biggest thing.
Well, and I think right there, that could help take care of the other issue in regards to them not feeling heard, right? If we could be able to ask that question, then they're going to feel heard, and that's going to make all the difference in the world, right?
Absolutely.
So, well, I cannot thank you enough for being here, Angie. I appreciate all your words of wisdom, and it was wonderful chatting with you.
Thanks for having me.
Thank you.
Thanks, Jay.
Thank you for tuning in to this episode of Neuro Navigators by MedBridge. Please be sure to subscribe and listen to more of our episodes on Spotify or your favorite podcast platform and at medbridge.com. If you're listening outside of the MedBridge catalog and would like to access the bonus resources and receive continuing education credit, simply log into your MedBridge account and search for this episode to find the accreditation details. Neuro Navigators also listens to you. If there's a particular clinician that you'd like to hear from, or if you have a clinical question or challenge that you'd like to see addressed on this podcast, please let us know by leaving a comment on our Instagram posts or by emailing podcasts@medbridge.com. As we wrap up today, remember that your dedication makes a difference. We appreciate you being here to navigate these topics and hope you enjoyed our deep dive into everything neuro. See you next time.